Good afternoon, everyone. It is my pleasure as the current EWMA president to welcome you all to this first webinar on the topic of GP's role in wound care. My name is Kirsi Isoherranen, and I'm the current EWMA president and the head physician of Helsinki Wound Healing Center. And during my president term, I established this GP network, which I am very proud of. We have almost 10 very active GPs participating in this network. We have published, sent a letter to editor, to Journal of Wound Management, and now we can today enjoy presentations of 3 marvelous GPs. I will share my screen and present you some slides about EWMA, what EWMA is doing currently. The European Wound Management Association is a non-profit umbrella association, and we are doing a lot in the field of wound care. One of our goals is to produce a very high-level documents. Here you can see the recent documents published. There are 3 documents that are already available and freely downloaded on the EWMA website, and next spring we will have a document on palliative wound care. We have a lot of activities ongoing, and something that might be of interest for GPs is the EWMA compression therapy program and also the antimicrobial stewardship program. And you can find more info about these ones at the EWMA website. We will have our annual conference in the end of March 2025. And the day before the conference, we have 2 master classes, one about compression therapy and the other one about atypical wounds. We have our own journal, Journal of Wound Management, that is currently indexed in Scopus, CINAHL, EBSCO, Infomit, and Google Scholar. And you are warmly welcome to send articles for peer review. We have a really fast peer review process. And of course, we have our annual conference in Barcelona in spring, you cannot miss. But now, without longer words, it is my pleasure to introduce our first speaker, Dr. Sara Magalhães from Portugal. And Sara will present us GP's role in wound management. Please, Sara.
Can I? Thank you, Kirsi.
Yes.
It's all good?
All good, yes. Slides
Okay.
we see them and we hear you perfectly.
Thank you. So, hello everyone. I'm glad to be here, first of all, and I'm very excited for this webinar. So, my name is Sara Magalhães, and I'm a family physician with a special interest in wound care. And I am also a fellow of the European Association of Fellows in Wound Healing. And I work in the community wound team near Lisbon in Portugal. And today, as Kirsi said, I will talk about the role of general practitioners in wound care. I don't have conflicts of interest. So, When we talk about wounds, it is essential to distinguish between acute and chronic wounds that can also be called as complex or hard to heal in the literature. For example, we consider that a wound that doesn't heal within 4 to 12 weeks can be considered as chronic wounds. The prevalence of the type of wounds, the chronic wounds, is increasing. For example, because of the aging of the population, and with an estimate prevalence of 2.1 per 1,000 people. And these wounds are difficult because they have significant physical, psychological, and social impacts, and they are considered a silent epidemic and a threat to public health. They are also contribute for 2 to 6% of the total healthcare costs in developed countries. So, when we see a patient with a wound, it became more important to look at the whole patient and not just the hole in the patient. And this is about the holistic approach in wound care. So, why this holistic approach is so important in wound care? Because there are many factors that affect the healing process of wounds, such as patient-related factors, like some of you can see here in the slide, like comorbidities such as diabetes, cardiac insufficiency, sometimes medications like immunosuppressors therapy or anti-inflammatory drugs, the presence of pain, psychological issues, allergies. There are also wound-related factors like the etiology, duration, size, anatomic sites, wound bed condition, ischemia, inflammation, infection, and some factors related with healthcare professionals and the healthcare systems, like the skills and knowledge of proper professionals, but also about the availability and effectiveness of some material or some treatments that we can propose to our patients, and of course the costs and the issues related with the reimbursement. But why is this related with GPs? Because as you know, GPs are the kings and queens of the holistic care. So it is easy to understand that GPs are, at least in theory, qualified to see that kind of patients, as we can see in this tree of ONCA, which represents the core values of the general practice. This holistic approach is crucial for providing quality care to patients with wounds. For example, GPs, we GPs have, and I will show you, specific problem-solving skills, and this enables to make accurate diagnosis of wounds and associate comorbidities using an holistic model, for example, and a person-centered approach. Additionally, when is necessary, we have the ability to refer our patients to other professionals. But why isn't this happening? What the literature shows us about the GP's problems and perceptions in wound care? We know, and the studies show us that there is a lack of pre- and post-graduated education in wound management, and there is a limited and fragmented access to guidelines, pathways, and educational resources. There is also a lack of confidence managing wounds and a lack of routines for wound diagnosis. and a lack of clarity regarding responsibility in wound care, and GPs also perceived their role in wound care as being secondary. So, what can GPs do to improve wound care? I will show you in the next slide some of the examples. For example, in wound diagnosis, we can improve this diagnosis. We know that some patients are treated by non-clinical providers, such family members or proper patients. And then some of the patients, or most of all, are treated in community-based healthcare providers, such as family practitioners, community nurses, and some of them will go to qualified wound care providers. But in fact, we are the primary care. We are the first medical contact within the healthcare systems of these patients. But besides that, in most of the cases, GPs were primarily consulted when wound healing did not proceed as expected, or when there was an expected problem, for example, a wound infection, and there is a need for antibiotics. And when it is necessary to involve other healthcare professionals, and this can be related with diagnostic delay. In this field, I would like to present an example of a study conducted by Kirsti and Kirsi, who are here with us today. And in this study about the diagnosis delay in primary care setting, 182 patients were selected. Almost 22% of the patients did not meet a physician before they visit the wound care team, and also 34.5% of the patients receive their first diagnosis by the wound care team, and the diagnosis was achieved within 4 to 12 weeks in half of them. So in wound diagnosis, we know that this process in primary care is lacking, and many patients did not have a diagnosis from their wounds. And we need accurate diagnosis with a multidisciplinary work between wound care nurses and GPs, because diagnosis is a prerequisite for treatments. As GPs, we can also take advantage of the continuity of care by following patients through the whole of their life. Establishing a relationship over the time can help us to know better our patients, certain aspects of their lives and illnesses, and their preference in a person-centered basis. Also, about comorbidities. There are a lot of factors that influence the wound healing, including aging, for example, or older age, and medications, pain, sleep disorders, and depression. And GPs can also do a very complete wound comorbidities assessments, because they have experience in management of simultaneous multi-pathologies. We also have knowledge in polypharmacy, knowledge in mental health, in pain management, in antimicrobial stewardship, and we can also promote and empower the patients and the family or caregiver. We can also play a role as care coordinator by delegate care when is appropriate, and referral to specialist service or other professionals. For example, wound teams in primary care or hospital care, but also dermatology, vascular surgery, rehabilitation, nutrition, social care, and so on. And we can also provide information to the patients on available service, for example, in community care. And what about prevention? Disease prevention and health promotion form an important part of the daily practice of the GPs, according to Europrev, in the all kinds of levels of prevention. And we know that preventing wounds wherever possible is more clinical and cost effective than managing wounds. So as GPs, we can identify risk factors such as that comorbidities that I have talked, promote patient health, including lifestyle changes, be aware and do early diagnosis, especially in patients with risk factors like diabetes or venous insufficiency. Educate patients to maintain skin integrity and protection, and advise and monitor the use of supportive products such as compression device, for example, in leg ulcer, and adapted shoes for diabetic people, and support surfaces for prevention of pressure ulcers. And to finish my presentation, we can also promote the creation of community-based wound care teams. We know that, and studies show us that providing specialized care can benefit patients by improving healing times and increase treatment adherence, decrease complication rates, and decrease costs. So, for example, in my team, as I said before, I work in a community-based wounds team in Portugal. We work in a multidisciplinary way with the physician and nurses. And between 2018 and 2033, we saw about 500 patients, and half of them don't have a correct diagnosis for their wounds. And we work in the with an holistic approach, and with this approach we reduce treatment times. You can see here in this graphic, we reduced in 2018 the treatment times in 68%, and in 2022 in 37%. So, in conclusion, GPs can play a pivotal role in wound care by contributing to early diagnosis. We can also promote an holistic approach to our patients and managing their comorbidities, and playing an important role in prevention, education, and as a care coordinator, especially when we are integrated into a multidisciplinary team. So if you want to know more about this topic, join us next year in Barcelona. See you there. Thank you.
Thank you, Sara. A very inspiring presentation and a perfect presentation for the beginning. And thank you for showing your data as well. And I guess that after this presentation, we can all conclude already that GPs are important, and especially when we are talking that prevention is more important than management of wounds, and that's where GPs are the gatekeepers as well. And I think the problem is how we can ensure in organizations that the GPs have enough time to do this task, and that is why we are here. Thank you, Sara, again.
Thank you.
And now it's my pleasure to introduce you Kirsti Ahmajärvi. Kirsti is my dear friend and my PhD student as well. And Kirsti is both GP and a geriatrician. And she's currently finalizing her thesis on the importance of wound diagnostics. And one thing I forgot to mention, that if you have any questions, please write them in the Q&A section, and we will try to answer them all in the end. But now I will leave the floor to Kirsti, please.
Thank you, Kirsi, for your kind introduction. Can you see my slides? First slide.
Yes, if you can put them on slideshow mode.
Is it now?
Not yet.
No. Is it now? Okay, I try again. And share.
Now, perfect. Now it's in the slideshow mode.
And now it's changing the slides.
Great.
Yeah, okay. Sorry, I technical issues. I'm Kirsti Ahmajärvi. I'm a GP and also geriatrics. And I want to say hello from the dark Helsinki here. So I need to have this light here because it's totally dark. And I have a presentation in this webinar about the importance of wound diagnosis. I have no conflict of interest. And Sara gave a very good presentation for the start of this webinar. And as GPs, or the first one to meet the patient with wounds, with nurses, we see this kind of wounds, and then we think about, oh my God, we have to make a diagnosis, and there's so many different kinds of wounds. And of course there are wounds, but we have to also be aware that there is a patient who is having the wound, and the patient is a person. So this is the holistic approach for the patient with wounds, as Sara was already indicating. We have to know something about normal wound healing. That normal wound healing has it is 4 phases in the healing process, and it starts from the injury with a blood clot phase, stopping bleeding, and also the inflammation phase starting from the very first beginning of the wound. And the inflammation, it is consisting of many cells and all the intermediators participating in the cascade of this process. And it's progressing towards proliferation phase and at the end of the scarring phase. And the problems of the wound healing are normally in the inflammation phase. So the wound healing process is stuck in the inflammation, so it's going round and round in the loop. There are several causes underneath that are causing imbalance of all these intermediates which are participating into the inflammation, and these causes are causing the wound healing to stop in the inflammation phase. And there are certain cells that are particularly participating, and they are especially neutrophils and macrophages, which are needed in progression from inflammation to the proliferation phase. And if these cells are not working correctly, then there is this loop of inflammation ongoing and ongoing. There are proteases which elevate the amounts. And all these microbiological changes, we see as clinical feature the diagnosis of the wounds, which we call the diagnosis. Well, we have to know that all these diagnostics have the base in the inflammation process, which is disturbed. When we have the patient with a wound, we should have the red flags. When we go, primarily the patients are treated by nurses, but when they consult or we have a patient, so the 3 I's we should consider. The first, ischemia, infection, and diabetes. Since these patients with ischemia or infected diabetic foot ulcers, they might have severe situation leading to complications such as amputations or mortality or septicemia or some condition we should treat in acute setting. So ischemia, if you suspect, we have to have the vascular assessment. Actually, we should make the vascular assessment for every patient with lower leg ulcers. We check the peripheral pulses by hand. We have to make physical assessment, and well, starting from arteria femoralis and popliteal, but here are the position of arteria fibularis and dorsalis pedis as well. And ankle brachial index, the measurement of blood pressure in the feet or in the foot is done with a handheld Doppler and stethoscopes, and normal is around 1. And we have to be aware of medial sclerosis, especially with the diabetics, that it might be falsely high because those calcified arteries are not, you cannot measure the blood pressure from those small vessels. And have the vascular surgeon or referral consultation if you suspect arterial ulcer. Diabetic foot problems they require neuropathy and peripheral arterial disease. We must make a patient assessment regarding these pathologies of diabetics. There might be a minor traumas, just some shear, you have bad shoes, or some just unnoticeable trauma, and then you have a wound, and it raises the risk for infection, and diabetic foot infection raises the risk for amputation. And there is 150 risk for lower leg amputation for the diabetic foot infection compared to diabetic foot ulcers without infection. And also increased risk for hospitalization. So this is very severe thing to assess diabetic people, their foot problems, and if they have vascular problems or infection. And Salava and Isoherranen has also published these 3 others as a mnemonic rule for 3 I's and 3 ADP. And this consists of atypical wounds, which have certain clinical features, and then conducting a biopsy, wound biopsy, and consult a dermatologist for the diagnosis and treatment. But the suspicion should arise in general medicine clinic. Distension, every other types of wounds should be treated with compression therapy if there were no arterial problems or need for revascularization, or the diabetics has been considered. Also, pressure ulcers should be, there are so many pressure ulcers and they are preventable. So the skin assessment should be conducted to the patients at risk, immobile, aged, in every phase of a treatment pathway. There is possibility for pressure ulcers. And if there are signs of pressure ulcer formation, make the related actions like offloading with repositioning and some assistant devices. There was conducted a questionnaire in 4 countries in Europe about the diabetic foot diagnostics in general practice, the population or questionnaire for GPs. And the result was that duration of diabetic foot ulcer was unknown or delayed in 2 cases of 3. And referral to a diabetic foot treatment units or specialized diabetic foot clinics, nearly half of them were referred after unknown duration or over 4 weeks. So there was referral delay for treatment of diabetic foot patients. And the diagnosis was 60% of the cases had the diagnosis due to patient's complaint. So it was derived from the patient, the diagnostic thinking. And 13 to 28% of the cases, it was incidental finding during the consultation. The patient didn't even complain that she had a wound. And from the same data, the GPs thought that the assessment of diabetic foot consists of a vascular assessment, neurological testing, and laboratory tests. But here in the table, you can see that the pulse check or ankle brachial index check was minority of the vascular assessment. And as well, monofilament testing for neuropathy was also in 9 to 20% of the cases. And blood test without any idea with no idea what to check, there was 9 to 28% having the blood test from the wound patients. And we had also data from a wound care clinic in Helsinki, consisting on 197 patients. And here is the variation of diagnosis. The first physician in primary care, probably in the emergency on healthcare, so some acute situation. There were no diagnoses in 26 patients and no specific etiology in 36 patients. And infected wound were 41 patients. And notable is that diabetic foot ulcers were diagnosed by the wound care team, and on the other hand, arterial wounds by the vascular surgeon. So these ulcers which should assess early, so they were delayed the assessment and the diagnosis. And here is quite the same. This is unpublished, but it's accepted in the International Wound Journal, and the figures for between 4 to 12 weeks, 1 to 3 months, the arterial and diabetic ulcers were in that group, the predominantly, but the post-traumatic ulcers that didn't heal, so they were diagnosed under the recommended 4 weeks. And delay in this data, the diagnostic delay was 56, median 56 day. It was the middle of this slide. WHO has created a pamphlet about diagnostic error, and delayed diagnosis is one part of diagnostic error. There might be misdiagnosis, delayed or wrong diagnosis, which are considered as a diagnostic error. And Panesar et al. Has thought that missed opportunities to make a correct or timely diagnosis based on available evidence is the kind of ground fault for the delayed diagnostic error. Schiff et al. Studied the diagnostic pathway or diagnostic process of a GP and found some points in diagnostic process from patient history, patient assessment, interpreting the findings, and making treatment plan. And they have recommended the actions to avoid diagnostic errors. This is modified from this article. There are standardized methods in the patient assessment, so we could have standardized assessment for wound care patient or wound patients. Identify red flags and don't misdiagnose those diagnoses that you just have to recognize in early phase to avoid patient harm. Use of checklists, engage patients as co-producers, as Sara was also talking about the patient in the center of the care, the holistic care. And safety netting is one possibility to give information to patient or the carers to take action if the case is not, a condition is not improved. For example, you treat the patient with antibiotics and there is no improvement, or there is some, you treat leg ulcer patient and it's not improving. So you should have the follow-up of the patient, so there wouldn't be delay in the treatment or the diagnostic process further. Not always the diagnostic process is that kind of that we it's not always in one point, but it's a process. We think of something and then this is not working, so we see the patient again and we reevaluate the diagnosis and the treatment. So it is a process, and we have to have the patient with to understand the process kind of thinking in this diagnosis. And then there are tools like checklists which guide through the assessment process, and they are structured, and the digital checklist, they bring valid conclusion and suggestion how to move on with the patient, starting from patient assessment and then concluding something. Oh, how should you consult a specialist, or should you start some treatment for the patient? And benefits of wound diagnosis are, of course, there is a diagnosis, there is a treatment. We have the etiology-driven treatment. It improves the patient-related outcomes such as quality of life. And also the personnel, when we have the diagnosis, the personnel can participate the treatment of the wound in a holistic manner. And financial outcomes, of course, last but not least. And Julian Kest, economist from UK, announced in EWMA London, just a healed wound requires no resources. So the wound healing is the one we aim at. We all professionals and the patient and the whole system. Thank you. We are the mental workers.
Thank you, Kirsti. An excellent presentation as well, and very, I could say, convincing data as well. And I guess it was David Armstrong who already in 2007 compared the burden of chronic wound to diabetic foot ulcers to cancer. So it is still a little bit surprising how neglected the area might be in some organization, but it is great that we are here, and it is. I'm so proud of you, Kirsti, as you as a GP are doing research as well, because data is important to convince also for the advocacy. So together we are stronger. Thank you, Kirsti. And the last but not least speaker we have is Tomi Ranta, and he is a friend of mine as well, a GP from Viiskulma, from Helsinki Primary Care Wound Care Center. And there is a quite nice history that Kirsti was one of the pioneers in that wound care center doing research, and now Tomi is continuing Kirsti's work and developing the concept further. So you, Tomi, have today the topic about wound assessment. Please, Tomi, the stage is yours.
Thank you very much for the introduction and this possibility to be speaking to all you interested GPs. I will do my best to share my screen, and hopefully you are starting to see my screen. And my topic is a little bit more hands-on, something concrete you can actually try to do when you are facing wound patients. And I have no conflicts of interest other than being a member of EWMA. So we are getting hands-on. So as GPs, we consider wound patients as a consultant. It's very nurse-driven, this whole process of a patient who gets a wound, how they get treatment. If there is no problems GPs have a very low role in treating these patients. But that is a little bit problematic, because if we have a patient, of course, a physical exam is very important. If we have a patient who has pain in their knee, of course, we examine them. But for wound patients, if we are consultants, it's too easy to just not touch the patient even. So I want to encourage you all to get your gloves on and really examine, touch the patients. The examination starts even before the patient enters your room. How is the patient walking? What is their physical capabilities? Do they need help walking? Then when you start to look at the wound, you want to check the bandages. They can tell you a lot. Is it does it have a great amount of exudate? Is there pus? Is there smell? So even before you look at the wound, you already get much information. And then one little bit neglected area we physicians can help our wound patient is managing pain. So of course, wounds are painful and we have topical anesthetics. But if the wound is very painful, I want to encourage you to use proper infiltration anesthesia, so the treatment is possible. In many cases, wound healing is not progressing because it can't get cleaned because of pain. And it's no difficult feat to use infiltration anesthesia, lidocaine injected in the wound edges. And while we are thinking about this and preparing with the anesthesia, we can get a patient history, ask the patient. In many cases, people have been visiting wound treatment for weeks or even months, and there is no clear history. How did the wound happen? What happened? When did it happen? And has healing been progressing? And there can be a little bit discrepancy between the physician and the patient. For example, some people have malignant wounds on their feet, and they are just think it's no big deal. Maybe it's some kind of trauma that caused the wound. But if it's been there for a year and it's not healing, you should have alarm bells ringing and think about take a biopsy. Then, of course, we need to treat infection, but infection is not the only thing that can cause delayed wound healing. So antibiotics are great drugs, but they are not a fix-it-all for all patients. And then, of course, we have to get the wound clean. And as physicians, we should have basic anatomic knowledge, and we should really examine the depth of the wound. It's not uncommon for the wound to look very small and superficial, but when you start to study it, you really examine it, you notice that, oh my God, it goes very deep. It can go all the way to bone or even into some joints. And when we are making treatment plans, we have to think about the patient. What is their capability? We can make unrealistic plans that the patient won't follow when they leave our office. So we have to take into account what the patient can do. And of course, need instruments. So I have some pictures. On the left side, I have different kind of curettes. We need something sharp to get the wound clean. In the center, I have a probe, a metal probe that we can use to check the depth of the wound. And scalpels and scissors are also good things to clean the wound. So a good rule of thumb would be to have the wound a little bit bleeding when you are done. Then you can be certain that you have got it clean. And of course, we can also check where is the wound. So thinking about basic physiology, we can think that if we have an arterial problem, peripheral arterial disease. They are more commonly on the periphery, on the toes or on the lower leg or the foot. And edema typically causes the wounds on the leg, lower leg, or around the ankle malleoli. Or if we think about mechanical stress, for example, diabetic foot ulcers, a telltale sign can be that it's developing a callus on the edge of the wound. And that can be an indirect message to us that, oh, there is still mechanical stress. We need the help of a podiatrist, offloading shoes to get rid of the mechanical stress. And of course, location can help us to identify pressure ulcers, heels, lower back, buttocks, or typical places. And then we have, of course, also atypical wounds, but sometimes GPs, they are not that common diseases, and we can be a little bit worried, can we notice it? But my message would be that they are so atypical that it's pretty clear to see. I have some pictures following. So assessing this depth, we should always keep in mind the basic anatomy. In what layer of skin do we think we are moving? Are we going through the skin? Are we going through the subcutaneous fat? Are we starting to get into deeper structures? And if we are superficial, of course, it's typically not so serious. We can try to do our diagnosis and try treatment, but if we are going into deep structures, we should be thinking about consultations earlier. And this is my only scientific idea, and this is this timers model. So if we see a wound patient that it looks worrying, your mind may go blank. So these timers can help you with that. So we are going through this tissue viability, checking for infection, thinking about the moisture surrounding on the wound, checking the edge of the wound, how is the healing progressing, and then these patient-related aspects. So first is tissue viability, and this is as easy as looking for color. So in the top right corner, I have this very beautiful picture of a wound. It even looks like a heart. It's nice and red. That looks very good to me. But then when we look at the other pictures, we are seeing bad colors. We are seeing black, we are seeing green, we are seeing fibrin slough. And that is something that we need to remove. And on this lower right, I hope you can see my cursor. So I'm pointing, for example, this looks a little bit atypical because the surrounding skin has some blue or violet color, and there is necrosis on the wound edge. So, okay, we start with timers. We start with tissue, and then we want a clean wound bed and all of the bad stuff removed. Okay, we have tissue done. Then when we move to next phase, we start to look at infection or inflammation. So this is a common pitfall. Everything that looks red is not infection, because edema also makes inflammation. Stasis eczema is very common. So for example, on this top picture, this is just stasis eczema. This is a patient of mine who received 9 courses of antibiotics, but the wound stayed looking exactly the same. The problem was edema and inflammation in the skin, not infection. So when we can, if the infection is not very bad, we can use topical solutions, for example, silver containing wound dressings. And we start to get the inflammation and infection controlled. Okay, then we move on to next thing, which is moisture. So we aim for balance, not wet, not dry. If we have ischemic ulcer and it's dry and black necrosis, then the rule of thumb is to leave it be and consult vascular. But if it starts to get infected, it gets soft, starts to have a smell, it pus coming, then we have to get it off. How we get the moisture balance right is a matter of choosing the right dressing. And many physicians have a little bit, they worry too much about knowing all the right dressings. My instruction for you would be to have a good team, have good nurses who know the dressings. There are thousands of them in the market, and you can control everything. So the nurses know the dressings, so it's not embarrassing to consult with your team. And then on the lower right, we have too much moisture, there is maceration, so we have to have the balance. Then we move into the next, which is the wound edge. And like I said, if there is mechanical stress, it's pretty common to see thick callus forming on the outside of the wound. And that is a message for you that you need to get rid of the mechanical stress, offloading more. And also one of the pitfalls is that there can be a lot of undermining or pockets around the wound, and they also need to be cleaned. So you need to be brave. Even if you can't see it, you have to clean the pocket. And then atypical wounds typically have abnormal color, blue or purple, on the outside of the wound. And when we get the wound edge, it is ready to progress and close the wound up. And then we need to follow up a little bit on how is the healing progressing. So getting a ruler and measuring in centimeters is very important. Your eye deceives you. So follow the centimeters, not just your eye. And if it's not progressing, okay, then think about maybe consulting or changing some of the treatment. But if it's progressing well, keep going. And in our outcome in this repair is we get the wound closed. And then also a very important thing about this is the social and patient-related factors. Like I said in the beginning, we can make a very good treatment plan, but if the patient can't follow it, then the wound won't heal. And it's very important to be empathetic and try to get into your patient's shoes, so to speak. So what are they thinking? What is their goal? What is preventing them maybe from following up your treatment plan? Is there economical issues? Is it, for example, I have this picture of a dog because one of my diabetic foot ulcer patients had lots of dogs and they lived alone and they had to take their dogs out to walk, and that caused stress on their foot, and no one was thinking and talking about that. We found a way to, they asked their friend to take their dogs out and we got the wound healed, but no one was asking that and it wasn't taken into account. There can be a little bit strange ideas that people have about wound healing. For example, that they have to have air, they have to take all the bandages off for time. That's not the case, and we have to discuss it with the patient. They might have ideas that, for example, letting their dogs lick their wounds makes them clean. And we have to talk about, actually, the dog, their mouth is not that clean, so maybe it's best not to let them lick it. And also, this like patient's own goals, psychoeducation. So getting a good doctor-patient relationship, that we have an understanding and trust between ourselves, that helps us get to the result. And I added one more last slide for me, which is something that we always have to be on the lookout, is cancer. So surprisingly, a lot of these chronic wounds are actually malignant. So especially if the wound is not below the knee, if it's in sun-exposed areas, on the face, in the hands, and it's not healing, especially consider biopsy. Of course, you can get skin cancer in the leg also, so you have to remember it also in the leg, but especially if it's in a typical location, think about biopsy. Okay, this was my hands-on approach for you all. Thank you.
Thank you, Tomi. Very inspiring as well. And this was like a nice cascade, starting with more like research and data, and then in the end, how to implement all this in practice. So I liked a lot. And you all, Kirsti, Sara, and Tomi, you are like running wound care. And here we have also Karin from Switzerland. Karin, please, you could also introduce yourself and tell a little bit what you are doing, please. You are muted, so if you open your microphone.
Hello, everyone. So I'm Karin Ahmajärvi from Switzerland, from the French part of Switzerland, and I joined the GP network. And I'm glad to see that a lot of participants are joining today this webinar. It's the first time we met in this kind of team. And yes, I have my own practice in Geneva in Switzerland as a GP, and I specialized in wound care too, and I like to work with nurses and dermatologists to have this kind of approach we discussed in this webinar. That means a holistic approach. And yes, we are, I think, the cornerstone for the wound care for our patients. And it's important to share our experience as a GP all over Europe and more. I saw that participants are from Peru too. So it's I'm very glad to join this team. Yes, I encourage everyone, every GP to join our group and to share his experience about wound care and wound patients. Thank you.
Thank you, Karin, and you can be now, all of you, the inspiration for these others in this webinar. And indeed, we have got a lot of compliments, and there is one question as well for Tomi. Do you work with a negative pressure vacuum system, and do you put silver gauze or something else? So a practical question.
Yeah, thank you for the question. And yeah, we do work with negative pressure wound treatment. In my opinion, negative pressure requires that you get the wound very clean and the infection out before you start the treatment. We have silver containing sponges, but I think I would prefer to say that first get the wound bed ready, and so that you don't have to worry about infection, and then use a normal sponge.
Yes, I agree warmly. And some advertisement that in the recently published MPVT document that is freely downloaded at EWMA website, there is a nice chapter as well about MPVT in primary care, and I think it will be of interest for you all. Great, I think we are now coming to the end of our webinar. This is the first webinar specifically for GPs, and I'm very convinced that we will continue these ones. And thank you all for your participation. Thank you for all the speakers, all the GP network members, and thank you, Amalie, for being here with us. Amalie is one of the EWMA Secretariat hidden, but always working very hard for all these activities. Can you show your face as well, Amalie, that we can see you? There she is.
Hello.
Thank you.
Thank you.
And if you would like to join us, you can always write email to Amalie or the EWMA Secretariat. I guess your contact details are in the EWMA at the EWMA website at the GP Network.
Yeah,
right,
I will also
Amalie?
write it
In the chat. Yes, perfect. Amalie will write her contact details in the chat. Tomi, please.
Yeah, actually, I think one of the first messages was like this WhatsApp group idea. That's something we haven't thought about previously, but I'm interested for a GP international WhatsApp group.
Yes, that would be great. There is indeed a number from Nedat Sivanovic, and Amalie can take that note, and we can also think about, we will have our next meeting next week, so we will plan for further activities and take this WhatsApp group as well. And indeed, Amalie wrote her email. Please be free to send any thoughts, any inquiries. And this webinar indeed has been recorded, and it will be in a few days at the EWMA website, right, Amalie?
Yes, exactly.
Okay, now we are happy and content, and I wish you all a joyful rest of the evening, and see you at EWMA Barcelona. Bye-bye.